Today, I'll be teaching you Camptodactyly. The incidence of Camptodactyly is 1% in the general population. And in the first part, we will discuss about the history and what will be the examination techniques. It will be followed by the management of the Camptodactyly. So let's see how to take the history and do the examination of Camptodactyly. The target should be to make a diagnosis of Camptodactyly. Remember that Camptodactyly is the permanent anteroposterior flexion contracture at the PIP joint, in contrary to clinodactyly, which is the radio-ulnar deviation at the PIP joint. Camptodactyly mainly involve the fifth finger, that is the little finger, and the major pathological basis is due to an imbalance between the extrinsic and the insertion of the intrinsic muscles, which is anomalous in majority of these cases. In the chief complaint, you will find that the informant always tells you that they observed this deformity either from the birth or during the infancy. So the first complaint will be the presence of bent finger, either since the birth or during the adolescent age. It might have worsened with time. Sometimes if there is an associated history of trauma, then pain may be also there as a chief complaint. So in the history of present illness, you are going to ask in details whether this flexion deformity or the bent finger was present at birth or was observed during infancy. It might have been noticeable during the childhood, and there is also a history of worsening of deformity. We will see that what are the classification of Camptodactyly which guide you towards the presentation history. If there is an history of physiotherapy or splintage during the infancy or childhood, then you must mention it, and obviously the history of trauma. Do not forget to take the relevant past history, the antenatal history, family history, immunization history, which are also part of a short case. On the local examination, you have to properly first expose the bilateral hands up to the forearm. There should be adequate light and a proper explained informed consent should be there. So whenever you are performing an examination in front of the examiners, do not forget these important points. So let's come to the inspection. The first is the attitude. Ask the patient to outstretch the hands with the elbow rested on the top of a table, and you notice the flexion deformity at the PIP joint in the little finger, ring finger, middle or index, whatever it is. You have to inspect both the hands. Always check for any fixed flexion deformity. You can ask the patient to flex and extend the PIP joint. And if there is a scar from a previous trauma or a previous surgical intervention, then you have to mention it in details. Coming to the palpation, first ask the child to make a full fist, and then you can also passively try. Then you check the active range of motion and passive range of motion at the PIP joint of the affected finger. And here you are going to differentiate whether it is a flexible deformity or a fixed flexion contracture. Because if you will flex the wrist and the MCP joint, if there is a change of the passive extension of the PIP joint, then it will give you an idea about a flexible or a fixed deformity. In the palpation, the most important is to do the central slip Tenodesis test. Look, you are going to check the integrity of the central slip in a flexible deformity, remember. Look, so what you have to do is hold the MCP joint in flexion, and if there is a change in the extension at the PIP joint of the affected finger, then if there is a complete PIPJ extension, it gives you an idea that the extrinsic extensors are good. But if during this maneuver there is any extension lag, then it means the extensors also need to be augmented at the time of surgery. Look for the movements of the joint and examine FDS and FDP individually. Sometimes what happens that FDS of the ring and the little finger may be interconnected and you will not be able to assess the fingers independently. So in that case, keep the ring finger free and then check the flexion of PIP joint of little finger, and then the same maneuver can be repeated over the ring finger also. Do not forget to check for the sensation and vascularity of the affected fingers. The final thing in the local examination is to measure the angle of the PIP joint with a finger goniometer. You have to look for the degree of flexion, the range of the flexion at PIP joint, and also the extension lag. If there is X-ray available with the patient, do check it before making the final diagnosis. You might get the findings which are congruent with camptodactyly. So how to make a provisional diagnosis at this stage? So this is just an example that it is a case of 11-year-old female with camptodactyly of the left little finger, type 2 category without fixed joint deformity. So you are mentioning the age of the patient, the finger and the hand, and also the classification of camptodactyly and whether the joints are flexible or a fixed deformity. So thank you so much, and in the second part we will also know about the management.